Welcome to June Department of Surgery Grand Rounds. I'm really delighted to introduce our speaker this morning. We've had a couple of days with Dr. Beck, and we had a symposium yesterday that was really wonderful. We exchanged ideas, and it was a great time for everyone. Dr. Beck is professor and chief of the Division of Vascular Surgery at the University of Alabama in Birmingham. He did his undergraduate studies at the University of South Alabama in Mobile, where he graduated with a degree in biomedical science and was magna cum laude. Got his MD degree at the University of Alabama, and then did his general surgery residency training at UT Southwestern, where one of his heroes was our very own Grant O'Keefe, who I hope is on the Zoom link. He did his fellowship in vascular surgery at Dartmouth Hitchcock, along with Matt Sweet. In fact, Matt Sweet took over as fellow for him as he was departing Dartmouth. Matt assumed control of his desk at Dartmouth. So that's a nice linkage. Numerous awards, numerous honors, societies, 7 visiting professorships, over 200 peer-reviewed publications, hundreds of presentations around the world and internationally. He's co-chair of the Aortic Research Consortium, which is you're going to hear about today. He has his partner named Kim and 3 sons who live in Birmingham, Alabama. So with that, I would like to say welcome, Adam. And he's going to speak to us today on spinal cord ischemia as the Achilles heel. Is it the Achilles heel for branched and fenestrated endografting? Adam.
Well, thank you all for having me. This has been a wonderful visit. I've got a long list of ideas that I've gotten. I love doing these visiting professorships because I get so many great ideas from places like yours. This has been a really great experience. These are my disclosures. All of the work that I do with industry is all paid to UAB and not me personally. I thought I would start out with this just telling you what my University of Washington connections are, and Ben just alluded to most of them. But as Ben said, Matt took my desk. Where is Matt? Is he in the room? Not yet. Maybe he's online, but I promised him I wasn't going to tell him all the stories I have about him. But he did take my desk, so he came there, and I've had the privilege of working with Dr. Zetterval also through the U.S. Aortic Research Consortium over the last couple of years, and then I've of course known Dr. Starnes for probably I guess about a decade now. I've gotten to know him a lot better over the last 5 years. And I always talk to people a lot about surgical heroes, is what I call these people that have been really impactful in my career thus far. And I'll say, if you don't know, if Dr. Starnes isn't one of your surgical heroes, you just don't know him well enough yet. He really has been an inspiration to me, especially with his position modified endografting, which I have always appreciated how you espouse the importance of knowing how to do this, because a lot of people are sort of embarrassed about it and they'll talk about it and they say, well, this is something you shouldn't do. And I agree with your assessment, and that people should know how to do this. All of you should know how to do this, because sometimes it's the right thing to do for your patients. I also trained at UT Southwestern, and Dr. Starnes was kind enough to share some slides with me. And this is something that's very important to me, again, about surgical heroes. Dr. Carrico actually was the chair when I got to UT Southwestern, and so I was privileged to spend some time with him as a trainee, and then also actually helped take care of him a little bit towards the end of his life as he struggled with cancer. Dr. Perry was actually at UT Southwestern and came to most of our M&Ms, and so we got to know him, and he did some of the teaching conferences with us. So I knew him reasonably well too. I don't know Dr. Mayer, but I know of him, of course, and I know of many of these gentlemen, of course, Dr. Shires as well. We had the Texas Mafia continued as Ben pointed out. And I have not spoken to Dr. O'Keefe since he left UT Southwestern when I think I was a second-year resident. It was 2002, but pardon my language, we all thought that he was a total badass. That it was such a loss. It was such a loss when he left there. So, and I'm certain that he has done well here. And then Scott Brackenridge actually was a resident behind me at UT Southwestern, and then was on faculty at University of Florida when I was there before he moved up here. And I'm certain that you all have really benefited from him being here as well. So I wanted to say at the beginning of the talk again, thank you very much for the invitation to be here. This has been a wonderful visit. I've gotten a lot of really great ideas from you about your training program and about the way you run your clinical practice. And this has been very, very beneficial for me. And I really appreciate all of you having me. And for, it's mostly vascular surgeons in the room, but I will tell you that a lot of times profits are not appreciated in their own hometown. I will tell you that this is a world-class vascular division, and you all should be very proud of what you've done here. So I'm going to talk about spinal cord ischemia today. This has been something that I've been pretty passionate about since I was really started in my job at the University of Florida because of my practice. I'm going to talk a little bit about the implications of spinal cord ischemia and some of the mechanisms, and then how we address this and what we've been able to accomplish over the last 15 or 20 years in reducing the risk of this complication. So why focus on a complication? I'm sure all of you have seen this quote from Rene Lariche, that every surgeon carries within himself a small cemetery where he from time to time goes to pray. This complication is often leads to mortality. It is certainly devastating when it's non-reversible, and it's something that you definitely carry with you when you see it. And so I really despise this complication, and so it's something that I've really been passionate about. As I said, the implications of this are pretty significant. So if you have spinal cord ischemia with an open thoracoabdominal repair, your mortality perioperatively is almost 50%. And this is not because of the complication itself, it's because it tends to not run alone. So patients have MIs, they get renal failure, they bleed, and some of those things actually lead to the spinal cord ischemia. And without spinal cord ischemia, your perioperative mortality is 1/10 of that, as you see. But with endografting, interestingly enough, sometimes it does run alone. So if these patients your procedure can go perfectly, everything can go seamlessly. You finish the procedure and the patient can't move their legs. So in those patients, even without additional complications, their mortality at a year is about 75%. So when you put that into the frame of a patient that you're seeing in clinic with a, let's say, 6-centimeter aneurysm, and their rupture risk is 5 to 10% per year, if you cause spinal cord ischemia and they die within a year, you've not done them any good. And so it's a very important complication to avoid. I was recruited to the University of Florida by Jim Seeger, who's the late Jim Seeger, who used to say all the time, write about what you do. So if you want to write papers, you want to do research, if you find something that falls within your clinical practice that really drives you, it really will make you a much better academician, in my opinion. So this was something that I was, as I said, very passionate about early on. I participated in a symposium at the SUS meeting in 2020. It was called Finding Purpose. It was a talk that I've never given anything like it before, but one of the speakers was also Gretchen Schwarzy, and she's a vascular surgeon at the University of Wisconsin, if you don't know her, and she talks a lot about sort of qualitative research and patient outcomes and mortality. I'm paraphrasing, but she said on a slide, write about something that you hate. And it really resonated with me because I despise this complication so much, and I would agree with her assessment. So thoracoabdominal aneurysm repair, you've all probably, those of you that have been around a little while have seen this. If you haven't, this picture is a patient that's opened up like a biscuit can. Basically, their chest and abdomen is opened up. This is an extent 2 thoracoabdominal repair that I did years ago at the University of Florida. Nobody wants to have that operation, obviously. If you look at the complications of that operation, depending on the centers that you look at, extent 2 thoracoabdominals carry a mortality somewhere around 10% up to 25%. If you look at the Medicare data nationally. So outside of centers of excellence, the mortality of even elective operation is quite high. Almost 100%, probably 100% of extent 2 thoracoabdominal patients have a major complication of some sort. Paralysis and paraplegia, depending on where you hear these reports, can range up to 40%. Depending on the urgency of the operation, and historically in the early days of thoracoabdominal repair, 20 to 40% was the number that was often quoted. This is one of the best papers, in my opinion, that's ever been written on the topic. This is written by Mimi Nguyen and C.W. Aker. Mimi is a cardiovascular anesthesiologist, and she did all of the anesthesia for the over 1,000 open aortic repairs that C.W. Aker did at the University of Wisconsin. They've got a series of really beautiful papers about this, and if you're interested in the topic, I would highly recommend that you read their papers. It's a relatively simple concept in that spinal cord ischemia occurs because of decreased blood flow and decreased oxygen delivery to the spinal cord, infarction, and then secondary injury, reperfusion injury, and cellular injury. So they developed a very nice protocol over the years that were addressing each of those issues. And so, and the concepts are that you increase the perfusion of the spinal cord, decrease the metabolic rate of the spinal cord with hypothermia or neuroprotective drugs like barbiturates and burst suppression, and increase perfusion by reimplantation of the intercostal arteries. So the things that cause spinal cord ischemia with an open repair are fairly obvious: bleeding, hypotension, aortic cross clamp, ligation of any of the branch vessels, or any chronic disease in any of the branch vessels. There are a number of adjuncts that we use with open repair, including CSF drainage, distal aortic perfusion, reimplantation of the intercostal arteries. My favorite, expeditious surgery, operate fast. Hypothermia, some people do spinal cooling. And then, as I mentioned, neuroprotective drugs, we actually use propofol, which gives you pretty nice burst suppression at a low dose. And with that, the spinal cord ischemia rate, depending on what you look at in the literature and which center it comes from, the rate is about half of what it was maybe 20 years, 30 years ago, 5 to 20%. So what about endovascular repair? It's a minimally invasive operation. It should be less, right? The first TVAR was reported in the literature in 1994. The Gore device was approved in 2005. The concept is simple with an endograft. You have to have seal above and below the aneurysm in order to achieve a repair. You cannot deviate from that. You have to seal above and below the aneurysm. Well, that's important if the length of coverage matters. And so really, if we look back at this paper by Aker and Nguyen, all of this is related to coverage of the aorta. Maybe not all of it. There's also branch vessels that don't include the area of repair. The patient can bleed, and then CSF drainage obviously can be used in these patients. But the most important thing is aortic coverage, and this has been pretty well documented in the literature for many years now. This is a paper that was written at the University of Florida before I arrived there in 2008, and it's a pretty nice paper. And basically what it shows is that the risk factors were increasing age, male gender, procedure time. So the longer the procedure, this is probably just a surrogate for complexity, and then the aortic coverage length. And this is a little bit hard to interpret at first, but basically on the top are patients that had spinal cord ischemia. On the bottom are those patients that did not. And so the white is the proximal uncovered. Oh, my arrow's not showing up. The white is the uncovered proximal distal to the left subclavian. Blue is covered. Orange is uncovered above the celiac artery. And so what you can see is the patients that had spinal cord ischemia had much more coverage of their thoracic aorta than the patients that did not. So we looked at this later, and when we had over 700 patients at this point. And one of the interesting things was when we looked at the totality of the 740 patients that we had at the time, and we compared them to the first 100 patients, the rate of spinal cord ischemia was the same. They had a 9% rate overall. Permanent spinal cord ischemia was 5%. So even though we had a lot more experience at the time, we hadn't moved the needle at all with spinal cord ischemia. It was about the same rate. Now it is lower than with open repair, but it was not different, and we hadn't really changed that much over about an 8-year time span at that point. So the length of coverage with an endovascular thoracoabdominal repair, like you see here, Sometimes we cover the entirety of the aorta, sometimes even from the ascending aorta to the bifurcation. And so it's a tremendous amount of aortic length that we have to cover. And what this shows is that the increasing length, again, increases risk of spinal cord ischemia and also increasing age. And so these were indications that we looked at. On the left are thoracic aneurysms with an almost 9% rate. But some indications actually had a much higher rate. Acute dissection, PAU, thoracoabdominal aneurysm was 15%. And then patients who had anastomotic aneurysms after a previous surgery had a 7% rate. So there was some very high risk patients, the thoracoabdominals in particular. And this is just looking at the observed rate of spinal cord ischemia based on your risk factors. So on the far right would be a patient greater than 80 years old, 300 millimeters of aortic coverage length, and a history of hypertension, and that risk of spinal cord ischemia was as high as 20%. So why do we care what happens? I already alluded to this earlier. This was a paper we looked at. All the patients that were alive after spinal cord ischemia, or we were able to contact their family members and talk to them about their patients, their family members' recovery after their spinal cord ischemia event. And at the time, we had 609 patients. This is again at the University of Florida. We had 57 patients that had had spinal cord ischemia at the time. And we kind of broke this down. I'm just going to show you some key Kaplan-Meier curves, but we had no spinal cord ischemia, spinal cord ischemia. So you can see that your median survival was half for the spinal cord ischemia patients versus the ones who had no spinal cord ischemia. Then we asked them if they had any functional improvement that they could appreciate. If they said they had no improvement, their median survival was 3 months. So these patients died. So the ones that are profoundly paralyzed, especially if they wake up on the OR table and they don't recover quickly over the next 24 to 48 hours, those patients very often are dead at a year. If they told you they returned to baseline, their survival was very similar to patients that had no spinal cord ischemia. If they did not return completely to baseline, all subjective, but if they did not return completely to baseline, they had a much worse survival. So it's important, as I've mentioned. So specifically thoracoabdominal repair, this is a paper published in 2008 from the Cleveland Clinic, and they had the largest experience by far at the time because of Roy Greenberg's practice. And I won't go through this in granular detail. I just want to show you it's a really nice paper. It's really the seminal paper about this topic, that they looked at their open thoracoabdominals versus their endovascular thoracoabdominals. This is a busy slide, but I want to show you that what I've just highlighted on the screen are the extent 1, 2, 3 patients. And basically, if you look at it, ER, SR is endovascular repair, surgical repair. This is mortality at 30 days. So the mortality was lower, basically, for endovascular repair. No surprise, it was about half of what it was for an open repair. But when you looked at spinal cord ischemia, it was actually pretty similar in totality. So even though this is a minimally invasive repair done through small incisions in their groins, the spinal cord ischemia rate was still very high. And so so this is based on what I've shown you already with the outcomes after this. This is a real problem when you're talking about elective repair in patients that you're treating for an aneurysm that maybe has a 5 or 10% risk of rupture. So you actually might be doing the patient more harm than good. These were specifically, and this is a different paper where they look specifically at the high risk patients, but extent 1 and 2 patients had a 10 and 19% rate. And so by this point, and this paper was published in 2008, I think, but by about 2014, I had a pretty good experience with doing position modified grafts. This was before I started doing the custom devices in my investigational device exemption study, similar to what Dr. Sweet, Dr. Zettervall have. I was doing PMEGs like Dr. Starnes was doing, and I had gotten progressively, I don't know if I want to say more cavalier or bold about treating patients with thoracoabdominal aneurysms, but I had a cemetery at that point, or at least a lot of patients that were that had some spinal cord ischemia. So I looked at this. This was 243 patients. This is 2014, and I had You can see this is juxtarenal aneurysm on the left, and you can see the increasing rate in orange of spinal cord ischemia. 30% of the patients with an extent 3 thoraco had at least some spinal cord ischemia, or what we attributed to spinal cord ischemia, some weakness in their legs. And these are the patients that had a permanent deficit. So extent 4, suprarenal, juxtarenal, none. The extent 3s and 2s were 5% and 11%. So very similar to the Cleveland Clinic experience. So part of it made me feel good because I had outcomes that were similar to a big busy center with a lot more numbers than me, but 10% is still an unacceptable number as far as I was concerned. So what can we do? Prevention is definitely key. And I'm going to talk to you about the preventative things that we do. Rapid detection is equally important. I think if you do enough of these, you probably have a story about a patient who you go in to talk to, you know, Mrs. Smith, how you doing, Mrs. Smith? She feels good. Can you lift your legs off the bed for me? Can't lift their legs. They didn't even realize that they had a motor deficit before you talk to them. And so this is why we have to be really on top of this in the ICU and make sure that they're getting their neuro exams frequently, because they can feel their legs most of the time. This is a anterior spinal cord injury, and usually it's a motor dysfunction that's predominant. So unfortunately, physical exam is what we have right now. Once the patient is post-operative, some people are using sensory and motor evoked potentials intraoperatively, which I have not found to be very useful. But a lot of people, including me, have looked at biomarkers of spinal cord ischemia, and unfortunately, that's not really panned out as of yet. So there are some spinal cord, there are some biomarkers that are axonal or pericarial that you can find after spinal cord ischemia, but they don't really help you with the diagnosis of this. And so as of yet, we've not done much with that. But what we do know is that treatment should definitely be protocol guided. This is a paper written by Dr. Randall Griepet in 2012, and this is another, he's actually got a series of these, but this is a really beautiful paper. And one of the things about it is just this picture, which I'll tell you, this is kind of an aside, but if you look at the collateral blood flow to the spinal cord and the vessels that form the collateral network around the spinal cord, they directly communicate with all of the paraspinous muscles. And a lot of these patients have back pain post-operatively. And I used to attribute this just to, you know, they laid flat on the bed in a position that nobody in their right mind would lay in for 3 or 4 or 5 hours. But this back pain is probably ischemic in some of these patients. And what you'll notice is patients that have spinal cord ischemia, a lot of times will have really, really severe back pain, and they may have a little mild leg weakness. But what they did was ligate the collateral blood flow or clamp the collateral blood flow to the spinal cord in juvenile pigs. And so what that top image is showing you is the vessels that were ligated. So you could ligate all of the intercostals almost in the chest before, with all of the other collaterals open, before you had any evidence of spinal cord ischemia. But if you ligated the subclavian arteries, which have some collateral flow to the spinal cord through the vertebral arteries and through the shoulder collaterals, you couldn't ligate the vessels close to the diaphragm where the artery of Adamowitz was, or you would get spinal cord ischemia. And then really interestingly, on the right of the middle sacral artery in a pig is very important for their spinal cord perfusion. And if you ligate the middle sacral vessel, you can only ligate 3 or 4 intercostals before the patient developed, or before the pig developed spinal cord ischemia. They also looked at 1 and 2 stage aortic repairs. And this is one of the things that really changed practice. People were doing this around the country, and some people were even doing intercostal embolization preoperatively. But what you're seeing here is that patients that had a 2-stage repair on the right, out of 35 of them, equal extent of repair, none of them had spinal cord ischemia. And so this is like an aha moment when we say, okay, well, if we stage these repairs, and the theoretically what you're doing is you're covering some of the intercostal vessels, and you're forcing the patient to develop collateral blood flow or enhance their collateral blood flow to the spinal cord, then you might decrease the risk of this complication. So again, back to this paper from Dr. Aker and Wynn, we decided that we were going to build a protocol around this and around this idea of staging. And so at UF, we developed this protocol, and I'm not going to torture you with all the elements of this, but basically it's got preoperative, intraoperative, postoperative elements. And the idea was we need to push the patient's blood pressure up. We need to enhance the oxygenation and flow to the spinal cord. We push their hemoglobin up, which was a bit of a struggle. As you know, there's a lot of controversy around transfusion. And so we don't transfuse patients typically until their hemoglobin is 7. Well, we wanted a target of 10 because that historically looked like it was, it had a impact on their outcomes based on some of the open thoracoabdominal data and from the folks in Houston. And then postoperative management, including CSF drains and again, pushing their hemoglobin up, pushing their blood pressure up, and increasing cardiac index. So in 2015 at Florida, we decided to implement this bundled protocol. And this idea of a bundled protocol actually mostly comes out of the pediatric literature with ventilator-associated pneumonia. So the idea is that there are some things that have good science, some things that are voodoo, and some things that are in between. If the things that are voodoo, like giving a Narcan drip, are pretty harmless, we did it anyway because there was some evidence that it might help the patient. So we created this protocol and we implemented it. And basically we said that all the patients undergoing branch fenestrated EVAR between 2012 and 2016 with implementation of the protocol in May of 2015, we were going to evaluate, and all the protocol elements were implemented in May 1st of 2015. So any leg weakness was assumed to be spinal cord ischemia unless some other pathology was identified. The patients that we defined in the study as high risk were those with a Crawford extent 1 to 3, and then zone 5 coverage. For those of you that don't know, zone 5 is just above the diaphragm, where the artery of Damquist typically is. And then patients who had a previous aortic repair were considered high risk. So we did all the things that I just mentioned. And if the patients had a suspected spinal cord ischemia event, despite the protocol, we had a rescue protocol that we implemented, which included things like lowering the spinal cord, the CSF pressure, increasing the cardiac index, and we would even put in a swan, God forbid, and manage that, raise their mean arterial pressure, increase their hemoglobin goal. We gave steroids, mannitol, and did a stroke evaluation to ensure that that was not the cause of their spinal cord ischemia. So what we found was, just going to click to this. So what we found was that the rate of spinal cord ischemia, of any spinal cord ischemia pre-protocol, was 13%, all comers, and post-protocol was 3%. The hematopathologist who ran the blood bank wanted us to look at our blood utilization, and that actually didn't change despite the fact that we were transfusing a little bit more. The overall blood utilization did not change. This is just showing those same data in a different way, but this is the patients with spinal cord ischemia pre and post protocol. And then if we looked at the high risk patients, we really impacted those patients tremendously. So it was really a pretty big win, I felt like, at that point. And interestingly, when we looked at the mortality was lower, and which is sort of a no-duh kind of thing. As I said, the spinal cord ischemia rate really impacts your mortality, even just at a year. This is a 1-year truncated Kaplan-Meier curve. So we recently looked at this in the United States Aortic Research Consortium, and this is a group that Dr. Sweet and Zetterball participate in. There are 10 centers around the country that participate in this consortium. For this particular study, we had data for 9 centers. If you don't know about this, you probably do, but if you don't know about this, this is, as I said, 10 principal investigators who all have independent investigational device exemption studies. They're all slightly different, but they're similar enough that we have custom aortic devices and patients, similar patient populations that we can compare. We enroll about 40 patients a month now in the US ARC, so it's a huge registry now. And as of last month, we had over 3,000 patients in the US ARC. So this is the largest data set of this kind in the world. So here we wanted to look at the risk factors for spinal cord ischemia. We looked at the pooled consortium data set for 9 centers. This was for all the patients treated between 2005 and 2020. So 2005, it's going to include a lot of the patients from Cleveland Clinic, where they had their IDE before anybody else. And we reference these to juxtarenal repairs, which has essentially a 0% risk of spinal cord ischemia. And we defined SCI as transient weakness or paraparesis or a permanent paralysis. So at the time we had almost 1,700 patients. The rate of any degree of spinal cord ischemia was about 7%. So there were 120 patients in that data set that had spinal cord ischemia. 3% were paraparesis and 4.2% had some permanent deficit. And this really recapitulated the data that we already know, which is that the extent of coverage is the most impactful risk factor. Age tends to fall out, and then interestingly, a history of peripheral vascular disease, or just assuming that this has something to do with collateral blood flow. And then if the patients had blood transfusions, and that fell out as a risk factor, but that's likely just because we either transfuse preemptively because we perceive them to be high risk, or we transfuse because they have spinal cord ischemia. And this Kaplan-Meier curve looks just like the Kaplan-Meier curve that I showed you already. Patients that have spinal cord ischemia do worse than patients with no SCI, but if it's a temporary paraparesis, they actually do about the same as the patients without any spinal cord ischemia. If they have paralysis, their mortality or their survival is much worse. So we essentially demonstrated again that the aortic coverage length matters and age matters, and so at least we have a really good idea of which patients are high risk at this point. And if you look at the totality of the data, if you look at the numbers that I've presented to you, we've decreased the spinal cord ischemia risk in the highest risk patients with all of the things. Not everybody uses the same protocol that we use. The data at our center look just like that data from UF. Our rate is about 1/4 of what it was before we started doing the protocol. If you twisted my arm and asked me what's the most important part of the protocol, I would say it's probably staging and blood transfusion. But we still do all of the elements that I mentioned. So in summary, spinal cord ischemia can be a very devastating, life-altering complication, as I've shown you, and a prevention, detection, treatment are key. I think protocol-driven care is very important. You must have this at a center that does thoracoabdominal aneurysm repairs. We know that it can decrease the rate of spinal cord ischemia. What I didn't talk about specifically, and I'll just mention now, is that there's a lot of controversy around CSF drains, and it's a controversy that was that everybody thought was done years ago. With open thoracoabdominal repair, you needed to do CSF drains because it appeared in 3 randomized controlled trials that were done in open thoraco repair. It appeared to decrease the risk of spinal cord ischemia. Well, now with all of these elements of the spinal cord ischemia prevention protocols that we do, even without a drain, the risk of spinal cord ischemia is much less than it used to be. The CSF drains themselves have a complication rate that's about 5 to 10%, depending on what you call a complication. If you include spinal headaches and things like that, it's about 10% of patients will have a complication of a CSF drain. Some of the complications, like an epidural hematoma, can actually cause spinal cord ischemia and paralysis. And so you may be doing more harm than good, again, by placing a CSF drain. And so we really think that there's clinical equipoise with CSF drains in these high-risk patients. And what we don't know, and what's never been proven, is whether CSF drainage actually prevents spinal cord ischemia. We know that if you have the drain in and you drain more, or you put the drain in after the patient has the spinal cord ischemia event, and you decrease the pressure in their spinous canal, you know that they'll start moving their legs again. We know that we prevent secondary injury, but we do not know for sure that drainage prevents spinal cord ischemia. And so this is where we think that it's really important for us to do a randomized controlled trial. We just completed a pilot study at UAB and at the University of Massachusetts. We did 20 patients, we randomized. This was just a proof of concept. And we learned a lot by doing that trial. And so we're going to expand this to all 10 IDE sites, hopefully, including University of Washington. And we're hoping to enroll enough patients to really answer that question. And I would say if I could do one thing in my career, if I can answer that question, I would say I'll be happy with that. So this was just a tweet when we enrolled our first couple of patients at UAB and UMass, and we've now completed this and are working on the protocol for all 10 centers. So again, thank you very much for the invitation. I really enjoyed the visit, and I'm happy to answer any questions.